coming up with ISR with good optimization. Thank you.
That's a great talk, Dr. Bhattacharya. And we have a big panel of experts here. Big guns are here. But what we'll do is we'll finish the next talk.
Yes.
And then we'll come back to the end for the questions.
Okay.
I welcome Dr. Sivakumar from Madurai to go ahead with bifurcation. It's a very common problem and also a complex problem. Dr. Sivakumar, if you're...
Yeah.
Thank you.
Bhattacharya, can you unshare your
Yes, please.
Yes, thank you.
Actually, my
That was a
screen
great
is
presentation.
gone. Fire up to my screen is now minimized. So,
Okay.
let me check.
Shall I go put continue or?
If you can unshare the third button, sir.
I could not find. It is in the browser, no?
No, it's next to the mic.
Oh, next to the mic. Okay, minimize self view.
Yeah.
Or shall I go with mine is asking continue. Shall I do
Switch
that?
screen to share. Click share to start sharing. No, it is again coming. Start sharing.
No,
It's okay.
that's okay.
Okay, I think it's done. Let me see.
Okay, I have done probably.
Stop sharing, yeah.
I have done.
Yeah. Are you able to see my slides, guys?
Yes.
Yeah.
Perfect.
Right. I'll go to the
Yes.
PowerPoint mode. Yeah. That was a fantastic lecture by Vijay Kumar and Kuntal. To save time, let's move on. Basically, the request from Saravanan and Mohan was to stick on to basics. So it's nothing new for expert panelists. But anyhow, at the end of the presentation, it's a shared knowledge, basically for the youngsters and the beginners, freshers, just to re-emphasize the basics. Hope I am audible and it's...
Yeah. Very much audible.
Hope slides are moving? Right.
Yeah.
So let me start with the saying, you never know what is enough unless you know what is more than enough. Having said that, we all want to have the result perfect. That's the ultimatum. But one should understand that the bare minimum is maze-free best outcome, if not a perfect result in every case, because bifurcation anatomy and its hemodynamics varies case to case. To introduce the topic, bifurcation, oh my God. Are you able to see my slides?
Yeah.
Sorry. It's been basically it's a complex vessel function structure where three different vessel segments like proximal main vessel, distal main vessel, and side branch are interpolated through a bifurcation core segment, where the distinction between the main branch and side branch is merely virtual, and fractal nature of the coronary tree pointing to the fact that coronary main branch tapers after the takeoff on a side branch. This is a famous Finet's law, wherein one can get to know the diameter of the proximal main vessel if you know the two daughter vessel sizes. That is, D1 is equal to D2 plus D3 into 0.678. Definitely this formula is useful, particularly when you are designing your strategy angio-based, if not imaging for various reasons. And when you coming to the stage of kissing balloon dilatation, where we need to know what's the summation of the two balloon sizes going to give up the proximal main vessel size. So definitely this formula somewhere in the step definitely helps you. So as said by Kuntal, whether it's a bifurcation, whether it's in the LM area or a non-LM area, the standard of practice is a provisional strategy. It is nothing a big deal about the techniques here. It is a philosophy here. One need to understand the philosophy of provisional stenting, wherein one should understand the concept. To the given anatomy, we need to know this philosophy is going to work, and the aim is being maze-free outcome. The long-term clinical outcomes are determined by the status of the main branch after the bifurcation stenting. Ensuring optimal results in the main branch should be given priority over optimizing the appearance in the side branch. If there is a fight between the main branch and side branch, one should not look into the cosmetics of the side branch at the cost of compromising the main branch result. So here comes the simple strategy for the bifurcation stenting. Here is a main vessel stented across the side branch with a wire in. The main vessel stent is based on the distal main vessel sizing. Having stented across the side branch, the proximal main was undergone a part. After the part, the operator is making it sure the result in the main branch is optimal. Once he made it sure the result is optimal in the main branch, now he is looking at the side branch. With an idea of keep it open principle, he wired it, and after the main branch stenting, he just looks at the side branch. If he feels okay, he can leave it. Or if after a jailed side branch, if he thinks he need to do something, he has three options like side branch opening, because already has done a part and repart, and side branch dilatation, kissing and repart, or he can do a side branch dilatation and kissing, which we are. So all the three, still any interventional lead will be doing it. Having done one out of the three in a side branch where he wanted to unjail it for some reason, now after ballooning, if he is still skeptical about his side branch result, well, he can go for a bailout stenting. So, having said that, the philosophy of provisional stent, let me take you through various basics of bifurcation. Like, we need to know the assessment of diameters of all the three segments, particularly the distal main vessel, side branch, and proximal main vessel. Is that philosophy of Murray or Finet's law is really happening? Because that is just a law. It may not be applicable in every case. We need to exercise that in that particular case, is it that really operating? This is particularly important in a left main disease where the left main looks, proximal main left main looks normal, but the two daughter branches, LAD and L6, looks big. Now we need to question the LM. It's a diffuse LM disease. So there is a feedback from the daughter branches to really get into the idea of so-called normally looking proximal main vessel. And of course, assessment of lesion length for the proximal main vessel as well as for the side branch, because side branch, the lesion length is very important. And plaque distribution, not only at the bifurcation core, into the proximal main vessel, distal main vessel, particularly at the side branch ostium, what kind of a plaque, particularly if it is a calcific plaque, we need to get into strategies like atherectomy or balloon-based or atherectomy-based preparations. Of course, the angle is very important. Still, angiography-based decisions on angle is quite good. Of course, OCT can help you in a further next level. But angiogram-based is also fine. Anything angle less than 70, one would look for a compromise of the side branch. Anything more than 70, you can make sure the side branch may not be compromised. And assessment of side branch ostium, which is always a critical in angiogram because the takeoff the main vessel may obscure, so you need to open up the side branch ostium to get an idea about the side branch ostium. Here comes the Medina classification, which we need multiple angiographic views and optimal views, as I said earlier. I am a transradial operator almost 98% of the time. It's a 6 French catheter can get away because in bifurcation always, even if it's a 2-stent strategy, it is step by step, so you can get away with 6 French. Sometimes in an SKS, like in ACS kind of a situation, one can go for a 7 French guide, which can be done in radial itself. So factors to be considered for the side branch are like size more than 2.5. There is one paper where the length, it is not only the diameter, the big artery important. The artery may be big, but maybe a length may be small. So we need to get into the idea of how long the artery is also. There is a paper saying if the length of the artery is more than 73 mm, the amount of ischemia is more than 10%. So long artery, big artery, and side branch ostium is more than 75% stenosed, and the lesion length extending beyond 5 mm. Why this 5 mm cut off? I will tell you at the later point of my discussion. And difficult access to side branch entry, and lesser the bifurcation, I said earlier, lesser the angle, greater the tendency to closure. Let's talk about something about wiring and rewiring. The rationale for wiring the side branch prior to main branch stenting is mainly the jailed wire, because you may, after main vessel stenting, you will suddenly, the side branch will disappear. Now only the wire is going to serve you to rescue the branch back. Particularly this can happen in an ACS kind of a situation, in NSTEMI kind of a situation. You lost the branch, so wire is serving to get the vessel back. Side branch wiring reduces particularly this happens in left main. Moment you wire it, it's a dynamic angle. The angle differs, thus setting in a more favorable anatomical position for rewiring and advancement of the balloons and stents into the side branch. They even say in left main, you redefine your angle after wiring it. Before the wiring, the angle may be different. After wiring it, the angle may be different. And having kept the wire in the side branch, it helps to advance the devices further. And jailed wire also can improve the side branch patency. Like in the provisional strategy, just keep the wire stented. The wire somehow dislodges the strut in a way that side branches remains patent. And in a worst case scenario, when there is unable to get the side branch back with a jailed wire, one can take the smallest available balloon, just open it. This is particularly useful in a left main scenario where there is a dominant LCX after the single stent crossover. Now LCX closed and the patient is crashing. There is no time, hemodynamic collapse. You are in a panicky where your wiring becomes very demanding. Now quickly take the balloon, just open it, get the vessel back, allow the artery to breathe, and just subsequently wire and retrieve your side branch. And jailed wire may serve as an anchor. When you use 3 wires, main vessel wire, jailed wire, of course, this is for the teaching purpose, not always because it is cumbersome. But in a situation where there is a main vessel wire, jailed wire, another third wire now is coming. The jailed wire is called as jailed buddy. Now can help you for a difficult side branch balloon crossing. So side branch wire is must when operators thinks that side branch is significant. So always keep the wire in the side branch when he thinks, not necessarily it has to be diseased. The decision is not based on whether it is diseased or not. In a provisional stent strategy, to wire the side branch, the moment operator thinks that side branch is significant to him, irrespective of the disease, he is going to put a wire there. Of course, in true bifurcation lesion, he has to do it. Always wire the most angulated branch to avoid the crisscross. After the main branch stenting, rewire the side branch to the struts with the main branch. That's what I said. Instead of taking the third wire, after the part, you have cleared the malo position, you can bring back the distal main branch wire to cross closer to the carina, that's a distal cross, and bring back the jailed wire and put it in the main vessel. Polymer coated hydrophilic guide wires have been clearly tested microscopically that they don't peel off and they are the best wires to jail. And only one wire is in the main vessel. The moment when the operator thinks that side branch is disease free and angle is a better angle, unlikely to close, and there is no great disease in the side branch, well, in a big LM, very big LAD, good sized LCX, no disease. Of course, I won't take a chance in LM, at least in non-LM, one can need not wire the side branch and you can get without a wire in the side branch, provided the angle is good and the side branch is not diseased. Regarding pre-dilatation, which needs definitely a discussion, optimal lesion preparation in the main branch with adequate balloon pre-dilatation facilitates stent sizing, main branch stent optimization, and it's a key to obtain a favorable long-term outcomes. So, your pre-dilation should be always based on your distal main branch or side branch size, based on which you deal the block well, because bifurcation is the one where you cannot take a chance on inadequate preparation, putting the stent and optimizing the result. Here comes the preparation not only for the ease of the procedure and also in terms of long-term outcomes. So keep optimizing your result step by step. You cannot chase it at the end. Side branch ostium pre-dilatation is controversial due to the danger of creating dissection plane at the side branch ostium, which may lead to one or more of the following. That's the reason there is a discussion on pre-dilatation, because unintended access to the side branch through a proximal strut of the main branch stent and increasing dissection distally in the side branch when rewiring and suboptimal angiographic result in side branch ostium haziness. Recently, I saw a case where in an LAD diagonal, after the main branch stent, just an operator overlooked the haziness in diagonal. You know what happened? There was a diagonal closure, then later on LAD closed. So one haziness in the side branch, which was overlooked, resulted in side branch closure followed by main vessel closure. So the predilatation which leads on to this havoc should be avoided case to case basis. When RCT compared side branch predilatation versus no predilatation. The advantage of side branch predilatation, the moment you dilate or you put a stent in the main vessel, the flow in the side branch looks bright. But on long term, there is no big difference between the TIMI flow in long term clinical outcome. That means the side branch which looks little compromised after main vessel stenting in a non-diseased side branch generally comes back without any intervention. So the call on side branch predilatation should be always based on if the side branch access is difficult. In case of severe or calcified side branch lesions, if the side branch flow is compromised after initial wiring. These are all the situations where I will tend to predilate the side branch. Regarding main branch stenting, as I said earlier, appropriate sizing of the main branch is important and avoid the malopposition of the proximal main branch because it helps to scaffold the side branch ostium. Of course, there is no debate between the DES versus BMS, and main branch stent diameter should be selected according to the distal main branch diameter because always for the proximal main vessel one can pot it. But if you select your size to the proximal main vessel, you definitely are going to end up in a distal main vessel dissection. And main branch stent should extend 10 mm proximal to the carina to when you do a part balloon to avoid geographical miss. And one should know stent design and expansion. There is a general law that for a DES stent you add 1.5, but that universal law cannot work because individual stents you need to go through their user information. 2.75 stent, how much it can be expandable, it varies to 4.2 to anywhere around 4.5 to different companies. One should know that to avoid distortion because we are all operating now with the second generation thinner struts where this limitation of maximum expansion and expansion at the cost of not distorting the stent is most wanted here. And oversizing the stent obviously will lead to carinal shift, block shift, main vessel deformity and tissue prolapse. This is the one imaging has brought out. When you do a over expansion, everything looks good, but tissue prolapse comes in, particularly when it is irregular, more than 10% of the flow area, then it speaks for the maze, inadvertent maze. And closed cell design, not recommended for a large side branch. And of course, it's a two-stent strategy always does. And how one can optimize the proximal main vessel, so-called proximal optimization technique. This is for the correction of the malopposition of the proximal main branch. It facilitates side branch rewiring by modifying the orientation of the side branch ostium and preventing the guide wire to go subintimally between the strut and the vessel wall, and facilitates the side branch ostium scaffolding and restoration of the circularity restoration of the circularity of the proximal vessel. Parts should be performed routinely after main vessel stenting to correct for the stent undersizing in the. So obviously you are going to select your stent to the distal main vessel. Always angiographically it will not be seen. Take it always there is a malopposition. Do a part, then you start wiring the side branch. So this is fantastically given in a diagrammatic representation here. You can see now the stent is as per the distal main vessel size. You can appreciate there is a nice malopposition seen in the circular view also. Now the pot balloon is coming. The pot balloon is parked just at the tip of the carina. The pot balloon is blown up. Now you can see there is disappearance of malopposition. Now you see, having done correct part in a side branch, the side branch has a disease up to 5 mm. There is, after the part, there is extension of the struts going and covering those so-called osteal disease within the bifurcation core. This is the reason I said one need to know why that is cutoff of less than 5 mm. The cutoff of less than 5 mm in a true bifurcation, even a single stent with a good part, repeat part, with an adequately sized balloon, can go and cover the side branch ostium. This is what we call it as scaffolding of the side branch ostium by a perfectly done, adequately sized pot balloon. And rationale for side branch opening and kissing balloon inflation, routine kissing balloon inflation doesn't improve. We all came to an understanding that it is no more routine and beneficial in circumstances like when there is a more than 75 stenosis after main vessel stenting with a lesser TIMI flow. And when you decide for kissing dilatation, it should be an NC balloon sized according to the distal side branch, and KBA should be done with the 2 NC balloons sized appropriately. So it is basically based on the distal main vessel, distal side branch. One need to know the Murray's modified Finnett's law also, how much it is going to give in the proximal main vessel. All this exercise should go through in your mind. And this is a classical, there is a main vessel, side branch wire. Now the main vessel stenting is happening. Then now the pot is happening. Look at here, the pot is happening with the jailed wire. That's what I was telling. The pot should be done with the jailed wires. Then only this preservation, the patency, favorably shifting the angle, all that's going to happen. Once a pot is done with the jailed wire, it is a choice between a third wire or taking the main vessel wire and do a distal cross closer to the carina. Then pull the side branch jailed wire, loop it and put it down. And now you are bringing the side branch opening balloon, which is also a kissing balloon, and you are bringing the kissing balloon. Look at the kissing balloon, where it is staying. It is staying only at the bifurcation core, not into the very much into the proximal confluence, because it will cause a deformity here. And once kissing balloon is done, we are doing the repart. Repart is just above the part balloon. The part balloon is up to the tip of the carina. Here in diagram it is not shown exactly. I will do repart just above, where this two summation of the balloons has caused some asymmetrical stent deformity, where I am going to target, not again into the bifurcation carinal area, because again it is going to disturb the carina. Not too much here. So it is, you are going to concentrate where we created the deformity. And well, you can do part side branch opening part also as an alternative. Herein, where you have stented, you have done a part, you are opening a side branch opening, and you are not doing a kissing. Because what happens when you do a side branch opening, there is a tendency for the main vessel strut to move and cause malopposition somewhere here. That's the reason you are bringing a part balloon again and doing a repart. Part side branch opening, the side branch opening causing a malopposition here. To correct that, you are doing a pot again. That also can be done. Let me quickly take you through one of my case. This is a left main, diminutive LCX, not supplying a great area, ideal case for a single stent crossover. After the preparation, OCT run was done and sized, length was decided. It is an ACS case, probably there is a rupture, and stent was brought in as per the OCT insights. And post-dilatation at the LM part. This is what the part I am telling you exactly. And this is what, again, we did with the 4 balloon. All these decisions were made by OCT. Now you can look at here. Angiographically, it looks great. And this is what we got. If you look at in the OCT, finally, if you look at the proximal segment, it is MLD max principle was applied here. MLD is pre-stent, morphology, lesion length and diameter. Post-stent, it is ruling out the dissection, and well opposed. Silver scale is really opposed and well expanded, because proximal diameter is 9.89, the MSA is 9.1, and distal is 9.1. So almost more than 90% as per the IVS XPL criteria. And this is the final angiogram. So having said that, in a bifurcation lesion, being a preferred approach being provisional, where one would defer side branch touching, or when the side branch remains more than 75 with the dissection and decreased flow and ischemia, one would go for a T-stenting tap or QLOT, or you can do a part side branch opening or a KBI, or leave it alone. When there is a debate, you can do an FFR and you can take a call. Let's move on to complex arena, where 111 or 101 or 011, I mean any kind of either of the main vessel segment with in addition side branch ostial narrowing in a more than 2.5 vessel supplying good area in a long vessel. One can go for elective 2 stents technique like QLOT, T or DK crush. if it's a true bifurcation, when you think the main branch, your premium interest, where you think the side branch is not going to close, you can start with T, tap or Q lot. Or in a case where you think side branch is your principal interest because the tendency for side branch closure is high, then you can do it a decay crush or inverted tap or inverted T or inverted Q lot. This is what a proximal cross. After the main vessel stenting, if you do a proximal cross away from the carina, look at here. There is a deformity of the main vessel stent. Not only deformity, there is lack of scaffolding of the side branch ostia. Whereas when you do a distal cross closer to the carina, there is nicely looking main vessel stent. Not only that, there is a good scaffolding of the side branch ostia. But not in every case you can expect a distal cross. There are situations where you may end up, particularly when you're doing a case with an angiographic guided stenting, and if you are there in a proximal or non-distal cross, don't take it as a proximal cross, non-distal cross, and you want to save time or distal cross was not happening in that case, not a big deal. If you made a distal cross, make it as a T stenting. If you made a non-distal cross, still you can make it as a Q-lot or tap stenting. This is a great insight. And this is a tap stenting. I will quickly take you step by step. In tap stenting, main vessel is stented, side branch stent is brought in, and it is protruded in a tap fashion. After the stenting, a tap stent balloon is pulled back. The ostium of the tap stent is flat. Already the pre-parked main vessel balloon is ready for the kiss, and report is done. And this is how it is going to look in a T stenting. When in distal cross, for some reasons, if it is a slightly non-distal where you want to convert it into a tap stenting, this is how tap is going to look like. And this is the case, double bifurcation involving LCX and OM as well as LM LAD. Wired OCT is done from LAD to LM. We can appreciate there is a block characterization, there is LM size, there is OCT pullback from OM to LM. You can see again there is a lipid-rich plaque, there is a thin cap fibroathyroma, there is no landing in the proximal LCX. Hence, the stent was brought in from OM to LM with a little protrusion into the LM in a tap fashion. It is an inverted tap. While I was doing, there is a tight pinch of the LCX for which a balloon was brought in, kissing was done. And so this is a case where in LCX OM provisional strategy was operated and got the flow back in the LCX OM. Then quickly we moved on to the LM arena with a stent from LM to LAD in a previously stented, slightly protruded LCX stent. On top of it, the second main vessel stent was done and final kissing was done. And this is a final OCT. You can clearly appreciate a nice figure of 8 with well scaffolded side branch, very little neometal carina. I call it as a reverse tap, Stripal Bangalore call it as nano decay crush. It is not the question of terminology, it is just a understanding of the bifurcation anatomy and how you execute the technique. And this is how the stent vessel looks like. You can clearly appreciate now the provisional strategy worked somewhere in LCX OM wherein the kissing balloon with the stent alone remained pattern. Here provisional strategy. Here two stent strategy with a tap stent first done and subsequently brought in the main vessel stent. You can appreciate neometal carina, nicely scaffolding side branch, well opened side branch ostium and main vessel. And this is the final angiogram. And this is a culotte stenting. Well, you start with the side branch into the main vessel, then you part it, then you get into the main vessel in a culotte fashion. You do a culotte stenting, then again you reopen the side branch with a distal cross. You bringing in a kissing balloon and do a repart. And this is how it is going to look like in a proximal main vessel. There are two layers. That's the reason decay crush did well in left main, because in decay crush there is no two layers. Of course, it is a good technique in non-LM bifurcation or in an LM where the LM is short. I think still the two layers are not so lengthy. One can opt for this technique. because the final kissing balloon chances is quite high. And this is my real world case. I call this as a remote culotte technique because this LED stent was done quite some time back with a protrusion into the LM, as said by Kuntal. I call it as a mini culotte. When he reached some time back, there was ostial tight L6 narrowing. We started with OCT from LAD to LM, which showed the patent stent, and not only it showed the patent stent, it clearly showed a good amount of protrusion to the LM to work on like a culotte fashion. That was the idea behind doing OCT here. We wanted to know how exactly it was protruding into the LM. Then, of course, the LCX pullback was done for sizing, and now the stent is brought in a culotte fashion because we know that a good amount of stent is into the LM, which is well opposed without ISR. So, brought in the other stent in a culotte fashion, and we did a pot subsequently. Then we did a final kissing, and this is a final OCT pullback. One can appreciate it is well opened. And this is a final angiogram, how it looks like. So it was an earlier stented single stent crossover with a good protrusion, which now got converted on OCT guided as a mini culotte. And this is my final case. Sorry if I'm taking extra time because I started 10 minutes later. And this is a side branch stenting with a pre-parked balloon in the main vessel, adequate protrusion. With the balloon, it is getting crushed. And after the crash, you do a first kiss. Then you brought in the second stent from main vessel to the main vessel. Then you recross, you do a final kissing and this time it is a distal cross and do a final part. And this is how it is going to look like. You can see now the crushed stent is sitting at the lateral wall and nicely scaffolded ostium and nicely opposed. And this is my real world case. This is my last case. And this is a 011 true bifurcation. And you can see now OCT run from LCX to LM to know the size, morphology and length. This is from stent from LCX to LM with a pre-parked balloon in the LM to crush the protruded stent. And now you can see after the side branch stent from LCX to LM with the protrusion, it is getting crushed by the pre-parked balloon, which is adequately sized based on imaging. Now what happened? This is a problem with the decay crash. Because you are starting with putting money on the side branch first. What happened? There was a pre-dilatation happened in main vessel also. By the time I did the crash, the main vessel got lesser TIMI flow, and hemodynamically patient was having pain and hemodynamically disturbed. So now I cannot take you through the steps of first kiss. So I quickly brought in the stent. So I skipped the step of first kiss. Brought in the stent, I moved to the stent crash, and of course I crossed to a distal cross and did a final kissing, and we did a imaging, just made sure that it is optimized not only in terms of any regular PCI, in terms of bifurcation optimization also, that side branch ostium, no much metals into the side branch. This is a pullback from LCX. And this is a final looking shot. Thank you, one and all. Let's take it for the discussion on the questions in the discussion session. Thank you, one and all.
Thank you, Dr. Sivakumar. We have a great expert panel here. It was a very nice talk, very, very clearly demonstrated the whole process of bifurcation. Dr. Damodaran, are you here?
Yeah.
Yeah, please.
Yeah, I'm here. Okay. First of all, let me thank Dr. Vijay Kumar and Dr. Sivakumar and Dr. Kundal. All have done an excellent job. In fact, Dr. Vijay Kumar has covered most of the areas we have not studied in our DM period, that basics. It's a really excellent talk, and I have learned a lot of things from his talk also. Coming to certain things, can we have time to even discuss about the physiology, or which is not routinely discussed?
I think we'll go with left main and bifurcation.
Okay. So then my approach for left main is very simple, in the sense left main or any bifurcation, both almost like similar. So I think bifurcation as per the latest trials, decay crash and other things. First of all, let me tell you what the operator should be familiar with at least one technique in a very expert way, because knowing so many techniques also may not give him much expertise when he started doing it. Especially when you are having a on-table cache, then it is only if you keep on doing it, you can doing it. And let me simplify this Lefman or any bifurcation such a way: simple bifurcation and complex bifurcation. Obviously, complex bifurcation, as Dr. Sivakumar nicely alluded, that Medina 111. And again, whether this side branch forms a major or sizable or functionally significant or imaging-wise significant vessel which needs a two-vessel stenting, or a vessel which may not need a two-vessel stenting, we can go for either a provisional or a two-vessel stent, elective two-vessel stent. My choice of late in the elective two-vessel stent is almost, I won't say 100%, almost more than 90% is only a DK crash. It is a very cumbersome procedure. Day before yesterday also I did one, almost taking 59 or 60 minutes of fluoro time. If you are going to do four times imaging, pre and wiring and post with the main and side branch, it is a cumbersome. But what to do? All these trials are showing that is the one thing which is almost reducing the outcome. Even the DK Crush 3, the left main trial, as well as the DK Crush 5 with versus provisional stenting. We have got a very strong belief that provisional stenting is going to really going to be the real savior in terms of long-term outcome. It may not cause any restenosis, whereas the DK Crush 5 has totally changed the concept of how we have to go about with the left-main stenting or a bifurcation stenting. So, in it's a simple bifurcation lesion where there is no osteal stenosis, where you find there is no abrupt closure of the side branch, as Dr. Shiva nicely told, that you need not even put a wire, but I am always so safe. I usually put a wire even if there is no lesion on the side branch, and I do a simple crossover stenting. But if you look at the latest data, the report clinical study, which totally shatters the concept of, though there are previous studies like Gopi's registry and other registries have shown negative effect of the final kissing balloon, even if you are not going to do a side branch leading. But this report clinical study, the recent study showed the real fractal geometry of the bifurcation morphology. When you are going to do a kissing balloon, you are going to deform the proximal stent by juxtaposing two balloons. And not only that, you are not going to the circularity of the proximal stent. And everybody knows that, but even then I want to reiterate it here. So then, obviously, it is not only that the arterial overstretch, maybe on the angiographic view may look nice here, but the arterial overstretch may cause a long-term stenosis. When it comes to restenosis, it is not only the main vessel restenosis, even the side branch restenosis. If you look into the DK Crush trials, even the side branch restenosis has much come down when you compare this DK Crush versus Coulott, almost 50% reduction. This is obviously various reasons you might have been known about that the covering of the side branch ostium and well opposed, all those things, the good MSA. But still, I feel the DK Crush has won over. Everybody knows that. So even for a provisional stenting in a simple lesion, we need to open up the side branch. And we, as he nicely alluded, I won't go for the first technique like a kissing balloon. Rather, I will do a pot, side branch, and repot. The second repot is in such a way you should not go and touch the, say the carina, because if it is going to touch the carinal tip, it will deform the carina. So you have to keep it. That also Siva has nicely emphasized. So this is my approach for a simple stenting. For a complex bifurcation, if it is a true complex bifurcation, there is a big, you are going to do a elective double vessel stenting. The only default choice is obviously DK Crush. I won't even, say about the other techniques unless it is an emergency, like in ACS where you are not going to perform. And Siva has shown one case before he was planned for a DK Crush and anybody in the LAD was closing, then you have to change it into a mini crush or whatever it is. So the DK Crush with the imaging is only going to give you the answer. Again, the DK, suppose if it is a complex bifurcation, you are not going to stent the side branch because the side branch size is very small. Obviously, you are not going to achieve anything. But there are factors, unfavorable factors for the potential abrupt closure of the side branch. Then what you have to do, obviously you have to go for a provisional stent. There is a technique by Chinese, it is not much popularized, maybe in the Western world it has been dubbed as a jail balloon technique. What I want to emphasize here, this is more of a balloon stent kissing technique I have been doing for almost more than 5 years. You have to keep a balloon, long balloon. Nowadays, getting a long balloon is very, very difficult. So you have to preserve your stent balloons, like a 25 millimeter or 30 millimeter stent balloons, and keep these, say, long balloons in the side branch, as well as keep the provisional stent, whatever the main vessel stent, and inflate in such a way you should not go with the nominal pressure with the stent, whereas the side branch balloon should be only at 4 atmosphere. Somehow there was a plausible explanation is this partially inflated balloon is somehow managing to correct the carinal or flock shift, though it is hypothetical. But one thing he has mentioned, Dr. Shiva has mentioned, whenever there is abrupt closure, you can thread in the 1.5 millimeter by the side of the main. That is a very, very tough issue. One of the Euro PCR, Dr. Stankovic, in fact, had and in a live, he had a abrupt closure of the side branch. In fact, he could not do it. Finally, what he did, he took a tornus or a microcatheter to thread in under the stent thread. So, because he has to restore the flow. So then again, as he told, he put the wire through the side branch, he saved the patient. Because even if it is a non-sizable, non-functionally important side branch, on the table, if there is abrupt closure, the patient may go in for a VT, VF and STEMI. So we must be very, very careful. So in case of true bifurcation, but the non-significant side branch, to save the side branch, we need to do a balloon stent kissing technique. I have seen that this is the best technique. The only thing is the balloon should be proximal to the stent so that it should not be trapped. And after deflating and taking out the balloon, you should try to wire in through the main vessel, but putting a loop because it should not go under the stent. And then you have to do again the same report clinical study. After removing the side branch, again you have to go for a pot and report side branch. If there is a need for a side branch, then you can do it. If there is no, then only a pot you can come out with that. As far as the true complex bifurcation with a sizable branch, I can only suggest here only one thing, that is DK crash. I don't want to go in for any other this one unless it is an emergency like an ACS, or if there are anatomy which may not be conducive of, because DK crash is mostly conducive of any anatomy, most of the anatomy, unless there is no heart left mind, there is no length of the proximal vessel to do a 6 millimeter pot. Because we have now balloons with 6 millimeter, that is the one thing I want to. So, and maybe we don't have, but a lot of doubts in FFR and physiology I will discuss with Vijay Kumar later on, because there is no time here. Thank you for the opportunity. Sarana, am I audible?
Yeah. Thank you. Yeah. Nice summary, Damodaran, actually. Yeah. We'll ask Dr. Keshavamurthy sir to say a few words.
There is no what to say. Sir, you have to give importance to this bang. Can you put some few words on bang technique?
You tell.
Now being a COVID time, all IVES, OCT are all out of the cath lab. Just simple stenting either of all left mine or whatever has been practiced. So let us say FFR and all definitely out. So let us wait for another 6 months for all these things. That is my approach now. Thank you. But it's an excellent talk by all three speakers, and additional information by Dr. Damodaran was very, very useful. I thank all of you for the discussion.
So Dr. Keshavamurthy has become a true COVID warrior, actually. COVID warrior.
Keshav, you look like a cinema hero, yeah. Keshav, hi to you, Shiva. I didn't say hi to you, Damodaran also. I didn't say.
Hi, Keshav is the innovator. He's not like a...
He has become a researcher. From intervention, he has become a researcher. Blue touch stethoscope, respirators.
Yeah. Very nice. Yeah, very nice.
Sundar, do you like to add anything?
I have a question for Kuntal.
I have a question to Dr. Sivakumar.
Go on.
I think you are doing OCT in most of your cases. I find difficulty when I use OCT for osteal-left-men. So
I don't do
you
it
have
in,
any tips, or you also use IVAS in osteal-left-men?
All osteal lesions, I take the help of IVAS, not in osteal lesions. OCT not in osteal lesions. Sure, it's IVAS.
Okay.
Kuntal, can I have a question for you?
Technique also.
Yes,
You have one technique for osteal lesions, no?
But whatever the technique, in a teaching forum here, I think Vijay Kumar will agree with me. For an osteal lesions, I think one should promote IVAS
I am
rather
just
than
joking.
OCT.
You are absolutely
Yeah,
right.
Kuntal, can I have a question for you?
Yes, please.
Yeah. Now the Excel data 5 years is out. There is little unfavorable widening gap between PCI, because I'm not sure. I have not gone through the details. This is my learning from the webinars. Anybody here, Vijay Kumar or somebody, Excel 5-year data little worrisome? Because whatever the available is 3 years data.
The worrisome
Anybody?
thing is,
Yes, I think
Dr. Kundal can explain.
yes, I think the inclusion criteria, they have taken large number of cases with bifurcation lesion. That is a major issue. And the imaging was very sparingly good. So that optimization was not adequate in my opinion.
No, actually, if you see that Excel data, it is almost 70% of the stenting was done with imaging. The main problem was the absolute increase in the mortality. I think 3.1% is the increase in the mortality in the PCA arm. But the main argument is that is actually a secondary endpoint. It is not the primary endpoint of the study. And another thing is there is a difference in the MI definition. So that has increased the more number of MIs in the surgical arm. So surgeons claim that has equaled the outcomes overall MACE events. But none of the other studies have shown increased mortality in the PCA arm, if you take any of the major studies. But still, we need how it goes because they are going to follow up to 10 years. And we'll know the real scenario. But if you take the PARCS group 10-year follow-up data, there's no mortality difference between left mind or this thing. And I have one or two questions for both of you, Dr. Kuntal and Dr. Sivakumar.
Yes.
So, Dr. Sivakumar, sir, you do all the things through radial, right? So,
Yes.
what is your incidence of left mind foreshortening? And another question is, do you always extend to the ostium?
This is a wonderful question. Being a radial operator, your choice between extra backup against Judkins is out, because all the time you need to work with extra backup. Then extra backup in a left main, you have a tendency. So we know that through transradially, being extra backup being the most of the time choice of guide, we see to that moment the left main, the stent, it is stented. Of course, whether it is extend to the ostium or not based on imaging, we take a call based on that. If it is a short ostium, well, we cover it up. If it is a long LM, we take a call based on imaging. Moment you put a stent, we immediately go for the pot balloon. We nicely oppose it. Make sure the proximal stented part is well opposed. Now, your manipulation of the guide sits against the stent wall rather than between the stent and the vessel. Of course, you need to keep vigilant every second to make sure. But once you are vigilant, once you size it properly, when you pot with the proper balloon, when you finish the part, then you are most of the time you are through. But with the second generation DES, it is always the case. One should make sure, particularly when you are protruding into the outside the LM, that is always there. And of course, when you are vigilant, it doesn't happen.
And because it is very, very important, if you see the Excel data, the incidence is 6.5%. And when you have this longitudinal deformation, the outcomes, 28% is the event rate. So that is one of the important things. Particularly, we observed most of the cases, I think we were doing a live course in LISI. So the stent was put from left main to LAD. In the end, we did OCT, that means there was no stent. All the stent was there in LAD.
Yeah.
So it is very, very
It's common
important
and
thing to keep in mind.
It is not because of the radial or femoral. The moment you are not vigilant, you have this tendency.
And
What is
another
your comment
question.
on Kuntal on this?
Yes, the same. Actually, I do radial, but in the left main ostium, I prefer to use femoral because the catheter manipulation is a bit easier because most of the time the radial catheter manipulation is difficult. So that is, I am not so much expert in left main ostium with radial. The another question to Dr. Vijay Kumar, sir. So what is your method? You do always intravenous adenosine, or you always sometimes you always do intracoronary also?
Always intravenous adenosine.
Always intravenous.
And one more question: what is the best balloon for your pot?
Pot balloon, I think you can do it with an SC balloon. For the kissing, you can do it with the NC balloon. Pot balloon being a single balloon based on sizing. I think you can get away with
because there is a lot of talk about the markers at the tip, at the end, or a little inside. So there are different balloons. If you take balloons from Thermo, Nabat, and Boston, all differ in where that markers are positioned. Exactly.
You should know how much the overhang. If you think the overhang is going to be high, you just stop a little bit above the tip of the carina. If the overhang is not much, stop at the carina. I think you can take the help of fluoroscopy. You will get a reasonable idea. Even if it overhangs much, the overhanging portion is going to be a conical. It's not going to grossly disarray the structures. So, fine, even if the overhanging is...
any preference between the compliant, semi-compliant versus non-compliant for doing parts?
I'm not sure, but the moment you asked the question, I thought it's semi-compliant, but it can be done with the NC balloon also. I think we can take the opinion from experts also. Meantime, I have a question for Vijay Kumar. How about, do you think this QFR and CT-FFR will come into vogue? See, now the resting indices have replaced FFR. There is a time predicted by Patrick Sarias. There is a day where the QFR with the angio impregnated with the QFR will become a way of practice. Do you think so?
I think it will become, because we were just initially thinking FFR was the way to go, then it has become IFR and this now. But there's a lot of studies coming up. Maybe I think all the companies, Philips, Siemens, all the companies are invested on this angiographic based FFR. They all take the volume, they take 3D imaging, so you do two views, they take a 3D imaging and measure the volumes, that is how it can reduce the FFR. And still the agreement is not very great, but once you get an agreement more than 80% with FFR or resting indices, and that should be the way to go. So you don't put any wires. And if you get something, still CT-FFR, the agreement is close to 60-70%, not more than 80%. But for sure, the softwares will develop in future, so it will become very easy. So for a chronic stable angina, there won't be any routine angiogram. Only do a CT angiogram and also CT-FFR. Only when it is a significant patient will come to cath. Most probably that is the way to go. Maybe 5 years time, that should be the reality.
Yes, Kuntal, other experts, Sundar, Sada and others, what do you do guys for the part, SC balloon or NC balloon?
We are comfortable with the SC balloon, sir, semi-compliant. I think most of the operators are using, or wherever we see in conferences or any webinars or any other thing, most of the operators are comfortable with semi-compliant.
They claim that whenever you use when you have a plaque behind your stent, that is where you need non-compliant balloon to expand your stent. That is you are meaning expansion, not apposition. But doing part is it is apposition rather than expansion. So they claim non-compliant compliant balloons. They just mold the stent better to the vessel architecture rather than non-compliant balloon. That is what. The proponents of semi-compliant
for an expansion, it is NC.
Right,
Vijay,
more of a portion.
One of the things we have is, for larger size, you have only compliant NC balloons.
Absolutely.
For example, if you want to have a short size, for example, 4.6 or 3.56, They are available now in some thermo balloons. So
Thermo Boston also has a 6 millimeter 4.55 balloon.
compliant balloon of 3 plus in the shelf because we don't use that often. So
Yeah.
I think most of the time we end up doing a NC balloon, but maybe not very high pressure. Depends on the underlying pressure.
Because I see Dr. Matthew doing always he does with the complaint balloon in the left main part.
Oh, okay.
So he claims this molds the stent better to the vessel wall comparing to, because you are just opposing the stent to the vessel wall, not expanding it much, because it is against the blood rather than the tissue.
Yeah,
So
that's a great
that
point.
is what they
Vijay
claim.
Kumar. That was excellent. Keshav, you wanted to ask
I
something?
have a question for you.
Yeah, please.
Shiva?
Go ahead.
Keshav
Yes, please
Murthy
ask
here.
me. Yeah.
See, why is that a basic question? I'm a junior guy. I'm basic question. Why is that? No. Why is it that DK crash results are better than TAP?
Yeah, this is a wonderful question. See, for the TAP philosophy to work, you need to have an angle which is closer to T angle, 90-degree angle. The moment you are putting a TAP stenting in an angle less than 90, obviously you don't get a T or TAP favorable angle in every case. That is a very rare angle. So most of the time the angle is lesser than T. So moment it is lesser than 90 degree, when you're trying to do a tap, you are going to protrude more struts, more neometal carina. So more side branch restenosis, ST, all kind of stuff. So that's the reason, particularly in left main, where you don't get this exact T angle. But when you do a tap, very meticulously in a T 90-degree angle, still it can come closer to the results. But unfortunately, the angles are favoring DK crush, where if you do it in a very nano method, little protrusion, crushing properly and stepwise, because the in between balloon case makes 3 layers into 2 layers, and that is how I think this is my guess because of the tap angle. Hope Kuntal, do you agree with this?
Yes, exactly.
Sir, this is actually one or two points I would like to share with your permission. And really
please.
Great disposition by all the 3 speakers, and it's a great initiative by Dr. Saravanan and Dr. Mohan. Really enjoyed, and so many things I learned today. So regarding DK crash, with reference to all other bifurcation technique, what they say, the stent opposition to the wall because of this double kissing technique process is good with the rest, comparing with the rest of all the techniques. So that one factor scores over the other for some favorable outcome. But then all distal left main or non-left main bifurcation, any of this procedure, the long-term outcome is not that good when compared to the single stent. Probably the more metal and then all other issues, whatever we realized. And some of the conferences, and even I attended one of the Dr. Vijay Kumar cases, they are doing, one or two cases with high definition 60 megahertz IOS. So probably, in future, if any of us, they want to put up a kind of IOS setup, please concentrate on that, and then comparing majority of the studies we used all 40 megahertz. There the vessel delineation, the lumen versus vessel wall is not that clear. Probably, we compared the 40 megahertz transducer with the OCT by chance. If you happen to see that, then you can have some better idea. And then it is not available in India right now. Say I have attended in other places. Say they say either OCT or IVAS, co-registration of angiography with OCT or IVAS. What is that? So say when you operate, in your screen itself, along with the angiography findings, the OCT or the IVAS finding will be integrated in the same picture. This is just a kind of a software update, but it is being already practiced at Europe and other centers. And what makes very easier there, in interpretation of this IVAS or OCT, right now what we are trying to do, we do angiogram, and then when they do this pullback technique, we say we started from here and this is where we are ending, all those things, because everybody is doing it. So you would have realized what I am trying to coming to. So,
Ilayaraja, sorry to interrupt. This ACR is being practiced in India as well.
yeah,
We are
Your
doing
center
Vijay
has a first integrated system.
even this 60 megahertz IWS and the so-called registration already, into the market. So not widely practiced. That's what I wanted to convey. And if somebody is trying to implant, those things, they can keep it in their mind. And regarding this distal left mind bifurcation, just I am sharing because